The broadcast is now starting. All attendees are in listen-only mode.
Good evening and welcome to the webinar on the radiological assessment of vertebral fractures. My name is Masaki Fujita and I am the Science Project Coordinator at the International Osteoporosis Foundation in Switzerland. I am also coordinating the Capture the Fracture Global Program. It is my great pleasure to run this webinar with our speaker of the day, Professor Harry Jennett. Professor Harry Jennett is Professor Emeritus of Radiology, Orthopedic Surgery, Medicine, and Epidemiology at the University of California, San Francisco. He was also the founder of SINARC. He is a globally well-known expert in the field of musculoskeletal radiology. Now, on to you, Professor. Please begin when you are.
Yes. Well, good morning or afternoon or evening to all of you. And first, I would like to thank the IOF for providing this opportunity to present this discussion of vertebral fracture assessment. Now let me, there we go. Okay, so by way of background, the importance of vertebral fracture assessment, we recognize that vertebral fractures represent a worldwide substantial percentage of overall fractures, and that they're oftenly not diagnosed by radiologists or clinicians. And it is likely that this contributes to unnecessary pain and suffering and to undertreatment of osteoporosis. So the identification of a vertebral fracture is important because the presence of a vertebral fracture greatly increases the risk of future fracture. And while there's wide availability of effective treatments, many patients go untreated, as you all know. Now, prevalent vertebral fractures are an indicator of poor bone quality. In fact, one of the best clinical indicators of poor bone quality. They confer a fourfold risk of incident vertebral fractures independent of BMD, and they confer a 1.8-fold risk of incident hip fractures independent of BMD, and similarly confer a higher risk of non-vertebral fractures. Again, largely independent of BMD. So prevalent vertebral fractures without major acute or remote trauma essentially equals a diagnosis of osteoporosis. And I want to emphasize that without major acute or remote trauma, because particularly in individuals, say in their 50s and 60s, it's not uncommon that there will be deformities related to physical activities and trauma earlier in life. We recognize that vertebral fractures are important because of their high frequency or prevalence, and this slide is from a very old study of Joe Melton, showing the prevalence of deformities, and I have that in quotes because this was done by morphometry, not by a visual assessment of fracture. So it probably overstates slightly the prevalence of true osteoporotic fractures, but nevertheless, one can see this very high frequency, particularly as we get into the older population, obviously. And of importance, overall, about 25% of women over the age of 50 will have a vertebral deformity, most of which, perhaps 90% of which, represent osteoporotic vertebral fractures. We also recognize that there's a very high rate of repeat fractures once an individual has had an incident fracture. So in the 1 year following an incident fracture, there is on the order of a 10% increased risk of fracture in that following year. If they have a single prevalent fracture at baseline, and if they have more than one, it's even greater. We know from many of the older clinical trials looking at the placebo arm that the prevalent fracture at baseline is a very strong predictor of incident fractures. And this, of course, is common knowledge at this point, but it was based upon examination of placebo groups in many of the early osteoporosis clinical trials. The classical article some years ago by Gelbach pointed out that many of the vertebral fractures that are present in an individual are not reported by radiologists. They undertook a study of some 900 women aged 60 and older hospitalized for various reasons and reviewed the lateral chest radiographs for evidence of fracture. And within this population of 900 patients, they found about 130 that had a fracture present. This is in a retrospective review of the radiographs. But only half of these had been mentioned in the report, and half of those had been mentioned in the summary. Fewer were in the medical records, and only 7%, in fact, were under treatment or had treatment initiated. So this is not new information. This type of study has been repeated, and this is a global problem. Recognizing the inadequate reporting of vertebral fractures, the IOF undertook the Vertebral Fracture Initiative. The first one was in 2005, and then once again in 2011. This time, the report, which many of you may have seen, it was published online and was available on CDs, included at that time, newer technology of DXA-based VFA. Now, the very large study undertaken of over 100,000 postmenopausal women who had baseline BMD and then were followed for a year and were examined then for evidence of fractures over the course of that year. Here we can see what the BMD distribution of this over 100,000 postmenopausal women was as a function of BMD T-score, with the mean somewhere on the order of a -1. But this shows the distribution in terms of normal osteopenia and osteoporosis. But if we look at the fracture rate that occurred in that 1 year, we can see that it was very much driven by the level of osteopenia to osteoporosis, with higher risk in those who are osteoporotic, as one would expect. But if we looked at the actual number of fractures that had occurred, we can see that many of those occurred in individuals who were osteopenic, and even some who by BMD had relatively normal skeletal mass. So this is an indication that by DXA or BMD measurement in general, that most patients with osteoporotic fracture will indeed have osteopenia or normal BMD rather than osteoporosis. And this relates simply to the fact that many, many more patients have osteopenia than those that have osteoporosis by T-score definition. So the overall objective is to prevent the vertebral fracture cascade in the extreme. And here we can see at baseline in this lateral image, we can see a vertebral fracture at this level. And then at 10 years, we can see that there has been further progression. And then at 20 years, multiple severe fractures all the way through the lumbar spine. I'd like to point out an interesting feature here in this mild fracture going on to a severe fracture. At this time, we see a fair amount of sclerosis of the end plates and extending into the vertebral body, and that typically is an indication of a relatively recent fracture, that is within, say, some months to perhaps a year, because over time that callus formation and reparative process stabilizes and you lose that. So this is one way that you can occasionally tell that a fracture is old versus a subacute fracture, as we see here. It's not entirely reliable, but it's something to be mindful of. So the challenge in assessing vertebral fractures is really to understand and have knowledge of the normal anatomy and the anomalies that may occur and distinguish that from true vertebral fractures. There are radiographic features that can be confounders, and one of those is the lack of an orthograde X-ray beam. Here the beam is orthograde to the end plate, so we see single end plates, and you see a parallelism of the from one vertebral body to the next. But if there is obliquity, which often occurs at the upper and lower margins of, say, a thoracic film or a lumbar film, it can simulate biconcave deformities, as I'm sure many of you are aware. Another feature that we should be cognizant of is the radiographic technique itself, and if one has an underpenetrated image versus one that is normally penetrated or exposed, it can affect the apparent amount of mineralization. This one looking radiographically osteopenic, this one not. So that can affect our interpretation. But what are some of the features that one may see that are at least suggestive radiographically of osteopenia or osteoporosis in the absence of fracture? And one of the features is the so-called empty box sign, where you tend to have an accentuation of the outline of the vertebrae, but it appears essentially empty and of a density comparable to the adjacent soft tissue. Here we see it in the lumbar spine, and similarly, we see it here in the thoracic spine. So that isn't entirely reliable, but at least it is one indication of likely, of at least possible osteopenia. Of course, we know that radiographs by themselves are not highly reliable, and that's of course why BMD became developed over the past 50 years. Now, another feature that you may see with osteopenia is an accentuation of the vertical striation, and this represents some of the accentuation of the vertical trabeculation as the horizontal ones become resorbed, but this is not very commonly viewed. You have to have excellent imaging to appreciate it. We recognize that a radiographic osteoporosis is not related only to osteoporosis, but many other conditions producing at least secondary osteoporosis or other metabolic bone disorders. Listed here are just some of the more common ones, and on our next slide, some of the less common underlying conditions. So it's important to recognize that not only the osteopenia or osteoporosis, but the presence of a vertebral fracture can be related to certainly secondary causes. Now, with typical postmenopausal osteoporotic fractures, there still is a wide variation in the appearances. Most commonly, even in relatively advanced vertebral fractures, you will see that some levels have only mild deformity. Others have moderate to severe. So it generally is not uniform throughout the spine, as I believe you know. If we look at this vertebrae, we see that the inferior end plate is quite straight, and the upper one shows this bowing or deformity. So this is not an oblique image, or else both end plates would have that oval configuration. This represents, in fact, a mild vertebral fracture with end plate impaction. On your right is an appearance of severe osteoporotic fractures, rather uniform from level to level. And this is a very uncommon appearance, even in severe, say, postmenopausal or male osteoporosis. As I said, it typically will involve one level more than another. When you start to see that type of uniform involvement plus the marked bowing of the end plates, then you might be dealing with a condition such as osteomalacia, classically in its advanced appearance, which we don't see very often in developed countries. One may have this type of diffuse end plate bowing. Another condition, Cushing's disease or corticosteroid exposure, particularly in high doses, may produce a so-called condensation of the end plates, or this sclerotic appearance extending some millimeters, 3, 4, 5 millimeters into the vertebral body. And this is in response to the fact that in the presence of corticosteroids, when end plate fractures do occur, there tends to be exuberant callus formation and until the exposure to corticosteroids is terminated. It also is an indication that these are evolving relatively rapidly, which of course can be the case when one is exposed to high doses of corticosteroids. This is an example of perhaps the most aggressive steroid-induced osteoporosis that I have imaging of, representing a 13-year-old girl with lupus who is treated with very high-dose corticosteroids. This is more or less at baseline, and this is within about 4 to 5 months. We can see that there is extensive compression of the end plates, and we're beginning to see as well that empty box configuration. I indicated in an earlier slide that when you have a relatively acute, typically say within weeks or months of the event, you may have this dense and broad sclerotic zone, but typically over a period of many months to many years, that is lost, and then you're left with the same deformity, but that sclerotic zone has resolved. Now, multiple myeloma, of course, can present with an appearance of diffuse osteopenia, as is shown here. But typically, you will also see some appearance of a spotty lytic tiny lesions or larger destructive lesions with myeloma. But occasionally, it will present with just a diffuse osteopenic appearance. Congenital anomalies, we have to be aware of and exclude them as fractures. This represents a deformity related to a notochordal remnant. It's an unusual anomaly, but you can look at this and you should be able to say that this is not a fracture. And the reason for that is that you look at the adjacent vertebrae and we can see that there's been overgrowth of the anterior portion of the vertebrae here and here. The anterior height is substantially greater than that of the posterior height. And that indicates that this is a lesion related that was present from birth or at least early childhood in order for this type of hypertrophy of the vertebrae to have occurred. On your right, we see typical appearance for a block vertebrae, again, a congenital lesion, and often then the waist AP dimension at the fused vertebrae is greater than the depth of the end plate at the levels above and below that fused segment. Another anomaly, this one provided for me by James Griffith, and he's provided a number of slides that I'll be showing from Hong Kong. Is a focal end plate deformity referred to as Cupid's bow. It involves the lower lumbar spine, typically L4-5 and 5S1, sometimes L3-4, where the nucleus pulposus is rather large and posteriorly placed, and it's often bilobed. And so on an AP view, it looks like a Cupid's bow, but on the sagittal view, it'll be a prominence of the nucleus pulposus that is a wide disc space here with extension into the end plates. This should not be mistaken for a fracture. Another acquired deformity is that of Scheuermann disease. This is also called juvenile apophysitis. Typically actually occurs during adolescence, during rapid period of growth, where the end plates are somewhat weaker, and it tends to occur in individuals that are sustaining a compressive loading to the spine. It results in a wedging deformity, irregular end plates at multiple levels, kyphotic deformity, which we see to some extent here, and these deformities will extend into adult life, but often the patient will be aware of the fact that they've had a kyphotic spine for many years, dating back to late childhood. Another condition that is very common is illustrated here in terms of so-called Schmorl's nodes and a limbus vertebrae, which is less common. The Schmorl's node represent the nucleus pulposus having herniated through the cartilaginous end plate. Typically, this has occurred in earlier life and can even be congenitally related, but there's a sclerotic margin to this Schmorl's node, similarly a smaller one here, and so this should not be mistaken for a fracture. At this level, we can tell that this has been present for a long time because the adjacent vertebrae has this overgrowth in this region corresponding to where the nucleus has herniated into the superior vertebral body. Now, down here we see what is referred to as a limbus vertebrae. It represents a fracture of the ringed apophysis, which is present in the spine until late adolescence. And if that happens to be fractured during childhood, it may not reunite. And so you can see this kind of a triangular configuration with sclerotic borders around it and this kind of a beveled appearance. This is characteristic of a limbus vertebrae, should not be called an osteoporotic fracture. Now, subtle mid-thoracic wedge deformities do not equal a vertebral fracture. And this, of course, has been emphasized in our early descriptions of the Jeanette semi-quantitative evaluation, and has been further emphasized by Dr. Jiang with the so-called ABQ approach, which is a algorithm-based qualitative assessment. And that is that you will see often mild mid-thoracic wedging, and particularly in males at the thoracolumbar junction, you see mild wedging, but without involvement of the end plate. That is, without seeing an end plate fracture or without seeing buckling of the anterior cortex. And this is shown over in the image on the right as well. And it is a normal anatomic variant, but it also becomes more severe with aging. Here's another example where we have mild wedge deformity, but the end plates are intact. And we do see that there's a secondary degenerative disease here. And over here in the lumbar spine, we have a rather marked degenerative disease, vacuum phenomenon of the discs themselves. We have sclerosis of the end plates, and this is referred to as degenerative remodeling and is fairly common, and particularly in men at the thoracolumbar junction. We don't have a fracture visible of the end plates. Also, you can look at this and see that this is a heavily boned person. Irregardless of the radiographic technique, you can see that these are relatively dense vertebrae, of course, denser than the adjacent soft tissues. So what is the basis for some of this, this kind of wedging deformity, as well as some of the sagging or bowing deformity of the end plates that one sees with aging, particularly in the lumbar spine? This may represent some element of insufficiency fracture or attrition, or the degenerative remodeling that I have referred to. Some work by Tanaka illustrates the evolution of changes as a function of aging in vertebral bodies. These would be a sagittal rendering. This is the axial or cross-sectional rendering of a young individual's vertebrae. Then with increasing age, we see the resorption of the horizontal trabeculae, accentuation of the vertical trabeculation, and a progressive sagging of the end plates. This would be in the lumbar spine, but in the thoracic spine, this could lead also to an increase in the wedging, mild wedging deformity prior to overt fracture. Further work on this was done many years ago by Vernon Roberts, who examined many cadaver specimens looking at the anatomy of the trabecular structure. And he was able to identify a very high frequency of trabecular microfractures, and this was on anatomic specimens. And here we can see a scanning electron microscope of this callus formation around this microfracture. And he showed in several of his illustrations the distribution of these in the older population. They tend to occur adjacent to the end plates and probably represent maybe a mechanism by which some of this more gradual evolution of remodeling may occur. One might also consider this to be attrition, as we see remodeling of, for example, the tibial plateau in the presence of osteoarthritis with cartilage loss. Now, it's not uncommon that you will have fairly rapid vertebral fracture progression, that is collapse. Here we have at day 0, at the time of that this was recognized, and this was a symptomatic fracture, and so it was recognized. We can see the end plate, in fact, has been fractured. We can see the progression by day 15 and on to day 36. Now, this certainly is recognized to occur, but it is somewhat uncommon, in fact, quite uncommon to have this amount of evolution over this type of short term, as we see here. But over a longer period of time, it's not at all uncommon to see that there is incremental collapse. So now I'd like to move into a discussion of the semi-quantitative evaluation for scoring of vertebral fractures, as well as recognizing a fracture versus a normal anatomic variation. First of all, we recognize that from in a given individual that there is considerable self-similarity as you go from one vertebral level to the next. You will also see that there is a pretty good parallelism of the end plates. That's an extremely important feature in distinguishing particularly mild fractures from more advanced. When they're advanced fractures, they're self-evident. Here we see similarly in the lumbar spine a self-similarity in the appearance from one level to the next, with a gradual change in the configuration as you go inferiorly. Typically the lower lumbar level, L4 and L5, are posteriorly wedged, which helps to account for the lumbar lordosis, which is a normal configuration. So many years ago, we started working with the semi-quantitative assessment, in part because of some of the deficiencies of pure morphometry, and developed this grading scale actually in the 80s, but this was the first major publication on this scoring. And of course, many of you are familiar with this. This is used widely in clinical trials as well as in clinical practice. The mild fractures representing about approximately 20 to 25% reduction, moderate 25 to 40, severe greater than 40%. They can also be categorized as wedge, biconcave, and crush, but we found relatively early on that often the fractures involve components of wedge, components of biconcavity, and so that distinction is less important clinically and in terms of prediction than is the magnitude of the deformity from mild, moderate to severe. Just another rendering of the scoring system itself. Now, if we look at the image on your left, we can see that there is a loss here of the parallelism of the end plates, and this in a magnified view shows this very clearly. And there would be no question about this being just a mild, normal, arthritic change. This represents and would be characterized as a mild grade 1 vertebral fracture. Similarly, at this level below that, we see again this very distinct appearance of a vertebral fracture. Onto a moderate fracture. The moderate is judged based upon the dimensions that I indicated, and also a loss of the cross-sectional projected area. And here's a demonstration of several severe fractures, grade 3. Now, when we're looking at incident fractures and we have a previous radiograph, it becomes extremely easy in most cases to identify an incident fracture because we have the comparative film. You're seeing the bowing that has occurred and also anterior buckling of the cortex that has accompanied this kind of a mild to moderate vertebral fracture. Here's incident moderate fracture. Clearly the end plates have fractured. We have buckling of the anterior cortex. The inferior end plate is similarly involved. So why grade the fractures? Well, it's been now shown in many studies that the baseline fracture severity, as well as the number of fractures, predict the risk of new vertebral fractures. Here, the data from fracture intervention trial with teriparatide in the placebo group at 3 years. And those that had no fracture at baseline, this was their percentage of patients having fracture. And you can see that there is, in fact, a rather impressive, almost monotonic increased risk, about a 8 to 10-fold greater risk with baseline severe fracture versus a baseline mild. But the baseline mild did have an increased fracture risk relative to those who were not fractured. Similarly, if we look at non-vertebral fractures, there is also a gradient of risk, but it's less distinct than for vertebral fractures, but nevertheless a far greater risk with the severe baseline fractures. So there is rationale for providing a scoring to the vertebral fractures. So a prevalent vertebral fracture and its severity predicts the subsequent vertebral, non-vertebral fracture, and is an indication of bone fragility and an indication generally for treatment. Now, we published a number of years ago a study that examined the severity of fracture in relationship to iliac crest bone biopsies that had been obtained. And this was from the study of fracture intervention trial with teriparatide. And what we're able to show is here as the baseline SQ grading, no fracture, mild, moderate, and severe. And this is one of the histological parameters, the so-called marrow star volume, which is essentially the size of the holes between the trabeculae. And most of the microstructural parameters from the iliac crest showed a relationship with the severity of the vertebral fracture. Now, another issue that we should discuss is the spinal deformity index. And this is a way of just simply adding the scores from all of the vertebral levels to give you kind of the fracture burden. So it's a simple means to do that, and it does have relevance. Here we look at fracture risk as a function of the lumbar spine T-score, showing fracture risk going up. And this is individuals with 0 score at baseline, in contrast to those that had a spinal deformity index of 1 to 3, 4 to 6, and 7 or more. And so the gradient of risk becomes even much steeper for those individuals with more baseline fractures. Now, I've mentioned the morphometry. This approach has been used in many of the clinical trials, generally combined with a semi-quantitative scoring, but it has problems, not so much with a normal spine because you can mark the points readily, but as you get into the elderly population with scoliosis and multiple osteophytes, etc., the methodology becomes more complicated and less reproducible. There is a software available that is useful as a work tool to help you organize your approach to interpretation of radiographs. This is software from Optasia that will automatically determine the vertebral levels, as you can see, or levels, as well as the configuration. Can also then automatically place the 6 points, but I would caution you that you always have to look at this very carefully because it is quite common that the point placement, particularly as you deal with oblique imaging, will not be proper. So you always have to double check that, particularly on VFA images, where often the points that are indicated by the software are not correct. Now, this kind of moves us into the topic of the vertebral fractures and VFA based upon DXA imaging combined with BMD, which of course is widely used now and is very convenient for the patient. We'll look at a few comparisons of the VFA imaging here using dual energy. When you use the dual energy approach, the contrast between the vertebrae and adjacent structures is much greater. The vertebral bodies appear white, as you can see here and are usually seen. And here we can compare it with the radiograph, thoracic spine, lumbar spine. And clearly you can see that the spatial resolution is much greater with the radiographs, and so it is more reliable than VFA, particularly for the mild fractures, but nevertheless, in this case, it is easy to consider this a normal study. Often with the dual energy approach, one may get some artifacts from diaphragm motion, as you can see here. Here we have the comparison radiographs, and I just want to point out that as we look more closely at the thoracic spine, there is a mild inferior plate fracture here, which one can see on this, but would not be detectable on the VFA image. And then if we look at the lumbar spine, we see some of this kind of biconcave configuration, but this can be seen as a normal variation, particularly increasing with age in the lumbar spine. We also see the reverse wedging at the L5 vertebral level. Now we'll compare. We can see that we have two vertebrae here that have wedge deformity. It becomes somewhat easier on the radiograph to judge the integrity of the end plates. Here we can see that there is some bowing deformity of the end plate and perhaps a slight break in this one. So that would indicate that these are likely, in fact, fractures, although they probably are of some considerable duration because of the amount of degenerative disease around this area where the biomechanics has been altered. Generally, often, the upper thoracic spine is not particularly well visualized, and particularly on the earlier generations of DXA imagers. Here in this case, this looks relatively normal through the mid-thoracic to the lumbar region. We look at the radiograph and we can see, in fact, that there is an end plate fracture here, quite irregular. This is not just obliquity. These are oblique. You see the oval configuration. This one actually shows irregular end plate compression. So the comparison of X-rays and VFA is quite obvious. The radiation exposure difference, the point of service that you have with the VFA, less of the parallax effect, lower resolution, but it may in fact show the lumbar spine better because there's less of that parallax than you have with a radiograph, but it certainly is not as accurate for the upper thoracic spine. Some of the earlier studies that were performed comparing a VFA and standard radiography showed a range of sensitivity and specificity being actually generally quite good. Sensitivity was variable, and most of the lower sensitivity scores were from studies that were done with the older technology. And so with the advances in technology in the last decade or so, the comparison with conventional radiography becomes much closer. Here we can see an imaging, the DXA system, which shows much better spatial resolution and image quality than the earlier generations of scanners. And here we can see a comparison of the Prodigy imaging, same patient with the DXA, and you can see visually that the spatial resolution and contrast have improved. Here with the hologic discovery system, and then with the Horizon, in a very large patient, some advantages for the Horizon where you can see that there is less noise and better delineation of the vertebrae than in this image in a very obese individual. Here with very state-of-the-art, and this is single energy imaging with a VFA, we can see very nicely here the fracture, severe fracture. And then if we look a little further down in the thoracic spine, we can see bowing of this end plate. So again, we have a fracture here. This lateral view shows potentially some changes. Let's look at it a little bit closer. Here we have a fracture of the inferior end plate. Here we see some buckling of the inferior end plate, so quite easily seen. And we look at the lumbar region, and we have definite vertebral fracture here. So the image quality now with state-of-the-art DXA is really excellent, and giving overall results that are approaching comparability to conventional radiography, with potentially the exception of the very upper thoracic region, which rarely fractures in isolation. The work by hospitals using state-of-the-art systems showed, in fact, a comparison for vertebral fractures using visual radiography, SQ radiography, and VFA, and showed a very close correspondence between these imaging techniques. Now, I'd like to end with a few slides on multi-slice CT or spiral CT, and then also MRI in characterizing vertebral fractures. So here we can see a reformatted image from a CT of the spine that was potentially obtained for other reasons, but in any event, here's a reformatted sagittal image, which shows very nicely a normal configuration. Over here we can see multiple level fractures. So the sensitivity for fracture detection with this type of CT reformation is very high, as well as the specificity. And here we can see a demonstration of the vertebral fracture cascade going from a radiograph here to some years later, multiple multi-level fractures and involving almost the entire spine. But again, notice that some vertebrae are quite fractured, others are less involved or uninvolved entirely. Now, there's growing interest in what is considered an opportunistic CT, that is using studies from the thoracic spine or the abdomen that were obtained for other purposes, retrospectively performing the reconstructions, as you can see here, and that can be done retrospectively. And then one can do a vertebral fracture assessment without any additional exposure to the patient or inconvenience to the patient. And James Griffith did an analysis of 450 thoracoabdominal CTs that had been performed in individuals over the age of 50, and 15% had at least one fracture. 42% of these fractures had been reported. The terminology used was ambiguous. That is, they didn't mention fracture in 86% of those, and fracture severity was not reported in any of the cases. Here are just some examples. Wedging, this was called, collapse, and here these had not even been reported. Of course, these studies are being done for other reasons, but we have to alert the radiologists and those interpreting these types of studies to the importance of vertebral fractures. Finally, a little bit about MRI detection as well as the CT detection. Typically, with CT, one will see the fracture lines, and one may see gas as well, and those are indications of a benign fracture, not likely metastatic fracture. Here with MRI and sagittal view, we have evidence of a vertebral fracture. Notice this is a T T2 weighted with fat saturation, so fat is dark, that the signal of that vertebrae is the same as the adjacent ones and is normal on a T1 weighted image, indicating that's an old fracture, at least 6 months to a year old, maybe older. And down here, we can see evolving fractures where there's edema and also some linear appearance. This indicates that these are acute or subacute fractures. So similarly with MRI, T1 weighted, T2 weighted, and now contrast has been given, but you don't need it typically, but if you do use it, you'll have a fairly linear configuration. Whereas if this were a metastatic fracture, the entire vertebrae would light up with the contrast. So some of the features that support a benign fracture versus a malignant. So preservation of fat in the vertebrae. A fracture line will be seen, fluid or gas, no extension to the pedicles, no large paravertebral mass, and preservation of trabeculae on the CT. So this is a typical appearance for fairly advanced malignant involvement with fracture. This is a typical appearance of an osteoporotic benign fracture. So I've covered a lot of material relatively rapidly, and I appreciate your attention for that. I'd like to acknowledge the Capture the Fracture initiative of the IOF, which has been ongoing for a number of years now. It's a global program for the prevention of secondary fractures by facilitating the implementation of fracture liaison services. And the key aims are that this would be a global voice, and it would drive national and international policy. It would help to ensure quality and provide, and the IOF provides support for these fracture liaison service implementation, getting started and improving these. This has been set up in over 28 locations, and you can see its global extent. Greatest density of involvement is in Western Europe. So I believe that
Thank you very much, Professor.
Masaki Fujita will now take over.
Yeah, thank you very much, Professor Giant, for your fantastic presentation and explaining how a good diagnostic can be performed. Thank you also for highlighting the difficulty but the importance of differentiating between vertebral fractures caused by osteoporosis and other forms of vertebral deformities. Now, I would like to move on to questions as we have received a number of good questions during the presentation. Now, I would like to start with question 1. Now, question 1, traditionally, diagnosis of vertebral fracture is from lateral spine radiographs. However, DXA may be able to replace radiographs for diagnosis of vertebral fractures. Now, both DXA and radiographs are used to look for fractures, but they may demonstrate the poor ability to differentiate mild VF from normal physiological variation. Now, does DXA miss fractures, or does spine radiography overcall them?
Well, okay, you may have elements of both, but you clearly have a greater capability to diagnose the more subtle fractures, particularly in the thoracic spine, with radiography compared to DXA. And that's because you have that ability to look at the end plate as well as the cortical margin to see if there's buckling or bowing, and that may not be as visible, particularly in the earlier generation of DXA systems. The later DXA systems typically will be able to differentiate fractures. But again, these milder wedge deformities, which often are normal in the absence of end plate fracture, that distinction can be made somewhat better by radiography compared to DXA.
Thank you for your answer and explanation. Now, I think we have time for one or two more questions. Now, second question. Some radiologists say that the statement on DXA images, image cannot be used for diagnosis, means VFA cannot be used for diagnosis, and won't report them. Can you comment on this?
Yes. Typically, that statement means that for other abdominal or thoracic pathology that is incidentally observed, it may not be reliably interpreted on, say, a DXA-based image, but it doesn't preclude the use of the system to assess vertebral fractures.
Thank you for your answer. And unfortunately, we only have time for one more question. So I would like to ask you, on behalf of one attendee, why don't radiologists mention compression fractures when they report chest X-rays?
That's a good question. Certainly some radiologists do and others do not. The focus for a chest radiograph typically is not related to the issue of osteoporosis. It's typically because of cardiac disease, pulmonary disease, and so that's where the major focus is. But it is an oversight that particularly a moderate or severe fracture is not commented upon. And the VFI, the Vertebral Fracture Initiative, was an effort to have both clinicians and radiologists increase their awareness of the importance of the fracture and to ensure that they be included in the reports. Unfortunately, that recommendation has not been uniformly accepted. I think many radiologists are more aware, as certainly clinicians are. And as you and I have discussed, it's possible that a new vertebral fracture initiative would further encourage that type of reporting.
Yes, thank you for emphasizing that important point. Unfortunately, we would have to close this questions and answer session as we are running out of time. Now, I would like to take this opportunity before we end this webinar to thank our sponsors, UCB and Amgen. Professor Jenna, if you could move on to the next slide. Thank you. And also for making this initiative possible. So thank you very much. And finally, to all attendees, thank you very much for your participation in this webinar. And we hope that you enjoyed this session. We will post recordings of this webinar along with the slides on the CTF website. You will find them under the webinar page. Now, upon termination of this webinar, you will be prompted to fill in a survey, and we would appreciate your input and comments so that we can deliver the webinars that can meet your needs. Last but not least, if you have additional questions, comments, or feedback, please don't hesitate to contact us at capturethefracture@iofbonehealth.org. Thank you very much, and Professor Janet, thank you again for this fantastic presentation.
Okay, well, thank you very much, and have a great day, all.
Have a great evening. Thank you. Goodbye.